Really nice to meet you all. Yeah, by way of background, I'm Matthew Harris. I'm a clinical reader in public health innovation at Imperial College, consultant in public health, and director of postgraduate talk programs. I've been working in global health for many, many years, with my career beginning actually as a GP in Brazil, in the Northeast, where I spent 3 or 4 years working within their system. And that has actually really influenced the rest of my career. In fact, what we're talking about is how Brazil has inspired the NHS with respect to this community health and wellbeing worker program, which I talk about. Listening to all of your backgrounds, I really think there's going to be something here for everyone, if I'm honest. It's a fantastic group that you've assembled here, because I think this really does touch on issues around delivery, workforce, commissioning, governance, community services, drawing on the community itself in order to support the community. So I think there'll be something in there for everyone, I hope. And as we agreed, I'm going to sort of talk at you for about 20, 25 minutes or so. What I hope to achieve in that will be just sort of a sense of what are the kind of things that community health and wellbeing workers are able to do in this context. Thinking through a little bit what some of the outcomes have been as a result of their work, where we're at in terms of the deployment of community health and wellbeing workers. I'd like to also tease out the differences between this role and others that we have within the system currently. So make sure that we understand how this is different and new, relatively new now, anyway, at least. And then also to begin to think about perhaps some of the operational aspects of this. It might seem like a simple role on paper, with perhaps very many similarities to other services or roles that we have within the system. But actually, it's quite unique in many respects. And hopefully, by the end of the presentation, you'll be able to understand that it's quite a radical, complex intervention, actually, that requires quite significant system level change in order to make it work. But work it does. And actually, I think what's quite exciting is we're seeing a lot of national appetite for this role across the country, which I'll also touch on, and hopefully thinking about next steps and how you might get involved if you think it's suitable for where you are. Confess, of course, I don't know very much at all about your context, so anything I say, please forgive any inaccuracies or lack of relevance or anything like that. It's as much for me to learn as it is the other way around. So very much hoping for this to be a dialogue and a conversation. I'm just going to start by just sort of touching on the fact that this has actually been an initiative that's actually been gained quite a lot of attention in the last, at least this year, actually. We've been implementing the community health and wellbeing worker role now for the last 4 years. It started in COVID, sorry, nearly 5 years now, with a pilot, which I'll talk about, and has been expanding. It's just been in this year where we've seen some really significant traction, national and even international attention, very much sort of hinging on the idea of a door knocking approach, which is what the community health and wellbeing workers do, this sort of proactive solution that's very much based at the household level, going door to door to tackle sickness and improve health and wellbeing for residents wherever they may be, and being, I think probably rightly framed as quite a radical solution. In part also because I think it coming from Brazil as a context, which again I'll touch on, is not one that we typically pay a lot of attention to, I think, in terms of learning from other countries. And so it's certainly been framed as sort of a radical low cost solution, and I actually think it is. But it's gained a lot of traction also from a policy point of view. So it was listed in the Fuller Stocktake report in 2022. Some of you be aware of it, as a best practice case study, and that was only a year and a half after the pilot began. It's debated in the House of Lords, mentioned in the House of Lords report, the future of primary care and community services integration, shortlisted for a number of awards. It was picked up by a variety of think tanks. It's even been mentioned now as a go-to strategy in the 10-year plan. Some of you may have seen it. And just today, in fact, after this, I've got to go and host the Brazilian Minister of Health, Alexandre Padilha, in the Westminster pilot. Well, it's no longer a pilot, it's actually an established service, because it's even reached the attention of the Brazilian government. They're here this week to sign an MOU with our government on a number of different health-related matters, including learning between the NHS and what's called the Sistema Único de Saúde, which is their NHS. So we're offering this, I think, as an already well-baked opportunity, I think, for international learning between our two great countries. So it's quite exciting. I'm going to just also start by just sort of giving a few examples about how the community health workers work. I've got a dozen here, but I'm not going to go through all of them. It's just a sort of a very, very quick overview of the sorts of things that they deal with, just to give you a sense of, I suppose, the opportunity, the complexity of their role, the sorts of things that they touch on are so comprehensive and so sort of addressing complex household needs for individuals and the family as a whole. But we often find, I think you'll agree, we really struggle as a system to actually resolve in a really sort of coordinated manner. So let me just give you a few examples of that. This was a case where community health workers stumbled across a couple that were living in absolutely dire housing conditions. This is all in Westminster, by the way. Financial difficulties. There was abuse where the female partner was actually abusing financially and physically the male partner. Um, Number of services had tried to intervene, couldn't really get to the bottom of it. They had severe health issues. The male partner hadn't visited the GP for many years. Community health worker developed a relationship with this couple, understood what the issues were, able to, through constant and consistent visiting over an extended period of time, which is part of their role, to facilitate multi-agency visits where the domestic violence could be identified and actually resolved, freeing up the male partner to actually be placed in temporary accommodation and building trust and then accessing healthcare services as a result of that. Um, over a 6, 7 month period, this was able to be achieved, even though it had been ongoing for, I think, many years without resolution. Another situation where, because of language barriers, a recently arrived migrant couldn't speak English, was socially isolated, was very lonely, and needing medical support because she was pregnant. And the community health worker, identifying these needs, encouraged her to join English classes, introduced her to local community centres, connected her with others within her neighbourhood, assisted her with registering at the GP, linked to the antenatal care services. And now she feels much more integrated in getting the care she needs with respect to her pregnancy and also within the neighbourhood as a whole. There's another example around digital literacy, again around social isolation. The difficulty with the digital literacy meant that this individual was unable to actually identify employment opportunities, but the community health worker provided the support, helped complete job applications, employment forms, provided digital assistance and training, and now this resident has been able to actually go for job interviews and actually been successful in one of them and is able to return to work. There's another example around bereavement support, medicine management, and immunizations being received. A resident experiencing significant back pain, pressure sores, dry lips, hasn't been receiving any of the either preventative or curative services that she'd been receiving, was socially isolated as well due to bereavement. The community health worker, again, building up the trust and relationship with that resident through proactive door knocking, was able to provide those tailored strategies, get the flu jab for the individual, sort the medications out, and connect her with wider community as well. So what I'm trying to just share here, and I've got multiple other examples around sort of resolving damp and mold and debt management in a particular household, sorting out mental illness and issues around physical issues around kidney stones, and then obtaining screening, antisocial behavior, getting health checks. We could go on and on and on. What the community health workers do is really identify through an in-depth understanding of the complex nature of these interrelated, intersectional issues of residents within families, within communities, where our current services just aren't able, because they perhaps don't have the time or they operate in too fragmented a way, or where they don't have the trust built up over time to actually get at the cause of some of the problems that the families are experiencing in all its glorious complexity. And so what the community health workers are able to do is I think through an in-depth understanding of all of that complexity, health and social care and its interaction, is actually identify that my colleague Connie Eulens explains it as a really complex ball of wool where it's difficult to find the first bit, and as you're trying to unravel it, the community health workers do that. They find the first bit of the ball of wool and undo the knot. And that's a sort of, but through connecting through other services and really an in-depth understanding of the family. We've tried to distill the secret sauce for the role into these four principles, um, that all need to be present in order for a community health and wellbeing worker to be a community health and wellbeing worker. And I'm just going to take you through them so that we're all clear about what those dimensions are, but also at the same time try and establish just how these dimensions make it different to the existing services that we currently have. So the first thing to say is that they're comprehensive. Hopefully through the case vignettes I just presented, you get the sense that they arrive at the household actually completely agnostic with respect to what they want, what they're going to do to help the family. They don't say, I'm here to help you with X, Y, Z, or, with your blood pressure. I'm here to help you get your immunization. I'm here to help you with your mold. They don't do that. But what they say is like, what's important to you? What's bothering you at the moment? Let's see how we can help. So the comprehensive nature of this is really important. They're essentially agnostic. They are led by the issues that family has at that moment in time. And that could be literally anything. They take an entirely life course approach. They don't just focus on the under fives. They don't just focus on teenagers. They don't just focus on people with chronic disease. They don't just focus on housing. They focus on the whole thing. So they won't, they'll think about breastfeeding issues, the immunization schedule, the cancer screening opportunities, the housing, the employment, the domestic violence, the social isolation, all at the same time, if that's the experience that's happening in the household. So the comprehensive nature of this role is really, really important. The second really important dimension is the hyperlocality, and that's to say that these are individuals that are recruited from the neighbourhoods themselves where they then work. It's putting the neighbour into neighbourhood health and care. And that's a really important feature because actually, I think a lot of our services are driven or let's say populated by people with healthcare qualifications, or they're professionals, very and have that sort of credential. We're recruiting in this instance regular people that have absolutely no healthcare qualification or anything similar. I mean, they might do, but we're not recruiting because of that. So these are regular people, residents in that community. And what we do is we allocate to them a neighbourhood of between 100 and 150 households close to where they're living. And that becomes their neighbourhood that they are then responsible for. And it's really important that they're part of that neighbourhood because that creates a connection, a sense of responsibility. It's that the residents can trust those people much more. There's a shorthand. They're familiar with the context much better than any of us could ever be with each of those different neighborhoods. And that becomes really a powerful, I think, signal, sends a really powerful signal to residents because it's sort of saying, I'm from here, but I'm actually here for you. So it's a very, very powerful, I think, an important dimension to have. The other thing that's really important with the hyperlocality is that these aren't volunteers, they're paid full time. And we'll come to the practicalities of that as well, I'm sure, in the discussion. The third really important aspect is the universality. So we don't, as we often see within our systems, we often find that we target individuals or households based on what we know of them already and what we think their needs are. So we'll target households or individuals because they've got diabetes or because they've got hypertension or because they are black or because they are Bangladeshi, whatever it might be, we target people. And this is a completely opposite approach. It's universal. They have their geography, I already mentioned, a discrete, defined neighbourhood. It might be, as is the case in the council estates in Westminster, these might be vertical neighbourhoods, buildings with 150 households within it, or it could be horizontal neighbourhoods. It really depends on your context. But the point is there's a geographical area that's defined, and the community health worker goes door to door in that neighbourhood without any sense of sort of targeting or prioritization. I mean, there will be priority areas, of course, depending on the needs that month, but every household gets a door knock. And that's a really important feature because the proactive nature of this role doesn't require a referral. There's no discharge. The door knocks happen each month or more frequently if a need arises for there to be more intensive intervention. But it continues over time, so an episode of support may have ended, but the community health worker will continue to knock on that household's door the next month and just check in and see how things are going, and so on and so forth. So there's no discharge either, unless the residents move out of the area. In which case, with a bit of luck, they'll move into another area where there's another community health worker serving them. So the universality aspect, I think, is really important. And then finally, the fourth dimension is the integration. They gather so much intelligence, so to speak, health and social care intelligence about the living environment, the context of that household, family, the members within the community as well. If they were volunteers, or if they were doing this part-time, or just for an hour a week, they would, or if they were not integrated into statutory services like primary care or social care or housing, in the local authority, they'd have nothing to do with the intelligence they've gathered. There would be no way to get things done. So a really important aspect of this role is that they have to be integrated into primary care. And this actually literally looks like NHS emails, a uniform, a logo, a badge, an email, an NHS email, the ability to enter information into the electronic patient record if required, the ability, dotted lines to the local authority, the housing department, social care, district nursing, community matrons, so that they can pick up the phone to each of those services and actually say, I've got a problem with Mrs. Smith in number 23. I think her wound is looking infected. Can you come over tomorrow? So that sort of integration is actually really, really critical, because then they can do something effective with the intelligence they gather during their visits. So without laboring the point, I think this is a good moment to actually think about how this differs to some of the services that we currently have. Because I think there are many services across the country that do fantastic work, there's no question, but they have two or maybe three of these four dimensions. But I think it's fair to say that none of them have all four of these dimensions. So you might, for example, have social prescribing link workers who will look at the individual in the round, certainly, but it requires a referral, a discrete period of time. There's a discharge, and therefore no ongoing relationship for the rest of time, as there is in this case. Community champions will may have a responsibility for their neighbourhood and be promoting health in all areas, but they often operate as a parallel system. They're volunteers, they're not resourced in that same sort of way, so they can't really easily make referrals or enter, certainly can't write into the patient records particularly easily. They're not part of the system. So I think we could probably think through a number of services that we currently have, and good exercise to think about how does it differ against each of these different dimensions, because I think you'll find that most of our services currently don't have all four of these dimensions at the same time. And that's what makes this different, in my view. I'm just going to take you through a few inconvenient truths before then coming back to some of the evidence base of this role and the operationalization of it. I think some of the things that's taken, I mean, I returned, for example, from Brazil, working there for 4 years as a GP in the system. I had 4 community health workers of my own. So I was inspired by the way that they work in Brazil, which is, by the way, exactly as I've just described. But it's taken 20 years to get to this point. Advocacy, research, trying to gather, attention and understanding of the role and its importance. And I think I just want to reflect a little bit on some of the inconvenient truths as to why it's taken so long, because it's really sort of delayed, I'd argue, a lot, the introduction of this role into the NHS, when we could have had it years ago, perhaps even pre-COVID, so that we would have had an army of community health workers like they do in Brazil. And I think one of the first things to say is that we have a tendency to think that targeted interventions are better than universal ones. We struggle to really explain how universal interventions actually are more cost effective in the long run at a population level than targeted ones. And this is really public health 101. Jeffrey Rose was the very famous epidemiologist. You might be familiar with this slide that showed that population health interventions where individuals stand to benefit very little from it, but at a population level actually leads to greater impact, are the way to go. So, for example, sugar taxes, right? We don't, as an individuals, benefit from that, but a population leads to huge differences on obesity. Seat belts, right, is the obvious one. We aren't all immediately and all the time benefiting from wearing a seatbelt, but that one occasion when you really needed it, you'll be thankful that you had one. So everybody has to wear one, so that road traffic accidents and mortality from them go down. Whereas in health services, I think we've developed a tendency to sort of just develop very vertical, targeted solutions that have served only really to actually fragment our system, possibly unhelpfully. We think sort of intuitively that targeting people with hypertension, targeting people with diabetes, targeting people who are black, or whatever color you choose, is somehow going to be more efficient. But I argue that actually that's actually not the case. It's better that you have a universal approach, picking up on problems when they're still small before they become too big. Then I think the second inconvenient truth we have is that we are very data driven rather than intelligence driven in the design of our services. And then I think this figure always reminds me of the learning from I think it was World War One or Two, where they were reinforcing parts of the aeroplanes that were returning based on the bullet holes that they discovered in those planes. And that all seemed to make a lot of sense at the time, but in fact didn't at all lead to any reduction in loss of aeroplanes at all. And they couldn't figure out why until they realized it was the aeroplanes that were not returning that they needed to look at. Yeah. And I think the analogy is very interesting because it's the people we don't have data on that's actually we need to provide services for. But we tend to design our services based on what we see in the data. And those are people that have already been able to access care, decided that they need care, have the wherewithal to get it, and so on. So actually, we're designing services, if we're designing it based on data in either primary care or secondary care or tertiary care, or people that are actually not being missed. Those are the people that are able to access care. So there's something around the proactive model here that's really important because it really picks up on the people that are unknown unknowns, people that we're missing. The third inconvenient truth, I think, is we're actually quite doctor-centered, so to speak. And when I say doctor, I really mean sort of health professional-centered in terms of the way we design care. So, for example, we did a little sort of survey, if you like, an assessment of all the services in North Wales at the time. 15 years ago now, we were trying to implement this role in North Wales and found that we had a plethora of different services provided to communities and individuals across the sector becomes actually quite challenging, doesn't it? Because you end up sort of, for example, you having 120 professionals for one household, whereas this model, you're saying you've got one person serving 120 households, but doing lots of things at that time. So it feels much more efficient, but it's community-led versus doctor-led. And I think we have to change that sort of paradigm a little bit in terms of thinking we can actually do much more with a lot less if we actually engage our communities and actually give them responsibilities, a mandate, the legitimacy to actually support residents where they are. In addition, I think what I find, at least, just reflecting on the last 20 years, is that we're very transactional rather than relational. We like to get things done, we like to do things, we like to measure what we've done. But some of the most important things that lead to outcomes, beneficial outcomes, really can't be measured at all. It's about how well do people get along with each other? Is the community cohesive? Do neighbours know each other? How are people feeling that day? A lot of this is based on love, it's based on trust, it's based on honesty and openness and communication. We're not measuring that. And actually, this role is fundamentally about building, gaining and maintaining trust between them as community health workers and the residents that they're serving. And that's not easy to do. You don't get that just by in an 8-minute consultation in the GP practice, sadly, these days. What you get is persistent, honest, open communication, breaking down those barriers, crossing the threshold, getting to know people where they live, and actually earning that trust and maintaining it so that they become, which they are doing now, the go-to person for all problems that that household has. And that takes time. That takes time. That's hard work, but it needs to be done. And then the final inconvenient truth, I think, I won't dwell on this, but has led me to do a sort of a whole research program, is that we really generally prefer to learn from the global north versus the global south. Now, this came from Brazil. This was an inspirational model in Brazil. Well, I'll talk about in a moment. They've scaled it to 75% of the entire population in 95% of the country. It's a masterclass in scaling, but it's a country that we typically just don't listen to, really, in terms of healthcare innovation. The top slide shows the global consumption of research nationally. where the size of the country represents the amount the research from that country has been cited. And you can see that actually there are regions of the world that are essentially rendered invisible, even though they produce fantastic research, we're just not consuming it. And that's leading into sort of a self-fulfilling prophecy and an endless cycle of what we might call epistemicide, the silencing of actually really important innovation and scholarship from certain regions of the world. We did this study in the bottom slide there that essentially, and I won't dwell on it, asked English clinicians to rate research on two time intervals, 1 month apart, same people rating the same research, but we fictionalized the authorship from either countries from the global north or countries from the global south. And to our horror, although not surprised, we found that the same people rated the same research much better when it came from the global north compared to when it came from the global south. And that's actually super problematic because we're saying we're really not scientific in how we consume science. We're influenced by where it comes from, which we shouldn't be. So this plays out significantly in how we then try and translate innovation. So these are just a few sort of verbatim quotes over the last 20 years, but people are quite resistant to learning from Brazil. I think less so now because it's gaining traction, but the last 15 years, people just didn't want to hear about it, not because it wasn't a good idea, but because it came from Brazil. And we have to reflect on that. So you can understand a little bit why they might think that, because at first blush, our context seemed very different. This was actually where I used to work. So these are the four community health workers I used to work with 20 years ago. We're a lot grayer now, but these are the same individuals, and they're still working in exactly the same community where they were 22 years ago. But you can see, abject poverty, it's a favela, significant social deprivation and economic deprivation. It was a really troubling area. But we have to sort of ignore that a little bit because actually what people need are the same, whether it's in this setting or in a council estate in Pimlico in Westminster. A little bit of support, a little bit of honesty, a little bit of communication continuously so that we can help people in real time on anything. And it's the same in Brazil and as it is in the UK. I mentioned that it's a masterclass in scaling. It's gone from 0 to 95% of the country in really just 20 years. And the outcomes have been remarkable. So, for example, this shows decrease in hospitalizations in areas, about 13% decrease in hospitalizations in municipalities where there's full coverage compared to municipalities where there's no coverage. This is showing that the cerebrovascular disease mortality and cardiovascular disease mortality has gone down by about 37% in areas that have high coverage of this model compared to areas that don't. So I mean that if that was a pill, we'd all be taking it, yeah. But it's not a pill; it's a system, it's a service. We did a little bit of modelling to show, well, what would we need in the UK, in England at least, if we had this model across the entire country, thinking about the number of households, household occupancy, distance to GP practices. And we calculated we need about 100,000 community health workers or so. In Brazil, they have 300,000. So it's not that it's not possible. We just have to have the political appetite to do so. But it would lead to significant improvements in cancer screening and immunization uptake, as we've shown in our pilot data as well, which I'll come to. This is just to show that we started in Westminster in 2020 with a very small pilot of 4 community health workers, but we're now through the National Association of Primary Care, supporting its scaling and sustaining across the entire country. And just 2 weeks ago, we had our second National Community Health and Wellbeing Worker Conference in Cornwall at the Eden Centre, where 100 community health workers came from all over the country to do training and share learning and share their experiences and ways of working in their different contexts. It was a fabulous, fabulous moment. In terms of evidence, you'll have to appreciate it takes a bit of time to develop the quantitative evidence because research is long and slow and needs to be published and all the rest of it. But our pilot in Westminster was published in 2023 that showed a very interesting, positive and unsurprising signal that those households that had been visited by a community health worker had a 47% increased likelihood of their immunizations being received, an 82% increased likelihood of their screening and health checks being received, compared to households that hadn't yet been visited during the pilot phase. Now, we're now doing a cluster RCT in Westminster because it's expanded to 24 different roles. So next year, we hope to report an even more robust evidence base around these outcomes, including GP attendances, which in the pilot showed a 7% reduction, and early evidence around A&E attendance and admission showing a 7 and 10% reduction as well, but not done yet, published data. So we're looking forward to doing that next year. In Cornwall, they've evaluated the improvements in the concerns that community health that residents have. And for the residents that were visited by community health workers, we saw a 91% improvement in the concerns that those residents had, whatever they may be, over a 6-month period. So they had a wide range of different concerns, from housing to mold to unemployment to domestic violence, whatever the concern was, 91% of them improved during the 6-month period compared to households that hadn't been visited. So the research team that used this measure, Meaningful Measures, have looked at this also in other roles such as social prescribing or community champions, and they'd never seen such an impact like this before. So it's very interesting and encouraging. I think I might not go through how it's done because I think we could do that as part of the Q&A, but there's lots of information I can give you around recruitment, training, supervision, funding, uniforms, boundary setting, integration with the patient records, our operations guide. But really just to say that, so happy to answer any questions on any of those things. Our next steps are around doing, as I mentioned, the cluster RCT. We've been doing research on its impact on themselves, the role, how's it improving them as regular people, how's this role help them in their lives, as well as community cohesion and resilience. We're doing health economics evaluation, and we're engaging with the Department of Health and Social Care regarding the 10-year plan, where they are having us now promote this role into 42 different neighbourhood health team areas that are part of the implementation plan for this project, for this 10-year plan. And then just finally, because it's personally gratifying, last year we were front page Daily Telegraph, no, 6 months ago, front page Daily Telegraph. And this is the editor, health editor, Laura Donnelly of the Daily Telegraph, visiting my team that I used to work with 20 years ago, who are still very much in post today, still looking after their community. So a very gratifying moment for me personally. I'll stop there.
Matthew, thank you so much. That's a lovely slide to end on. I've got about 1 million questions, but I'm the facilitator, so I'm going to try not to interrupt, but I'm going to keep the recording going, if that's okay, because obviously the AI will pick up the summary of this, which I think will be really, really helpful. So let's jump in and let's be polite, because there's a few of us. Pop your hand up with your questions. Okay, let's go Helen first and then Penny.
This sounds brilliant. It sounds really good. So what are the main barriers as to why we're not doing it?
Yeah, crikey, where do I begin? I'd say, well, in addition to the barriers I mentioned earlier, which I suppose sort of philosophical barriers to some extent, right? Targeted versus universal, etc. I think some of the barriers are around finding the funding. The community health worker role is, as I mentioned, very comprehensive, so it doesn't fit neatly into any specific funding pot that you may identify. What we see in all the different localities is actually a real risk that the funding isn't fit for purpose for a role such as this. It tends to be a bit too short term. People think mistakenly there's something you can do for a year. It isn't something you can do for a year. You don't bother doing this unless you can do it for at least 3 years. That it's something that you can fund with something that's really rather specific, like sort of funding for children's services. No, because if you use funding for children's services, then how do you justify helping people with their housing or their domestic violence or the cancer screening in the over 50s? It becomes very hard for it to stay comprehensive. And so you end up distorting the model as a result of that approach. So some solutions have been found, like, for example, using additional roles for reimbursement scheme funding, working with primary care networks to deploy that, or inequalities funding, or community development funding, or public health budget. Integrated care boards, I think, are really, really important to oversee the pooling, perhaps, if you like, of resourcing from all throughout the system. This is a role that hopefully you got the idea can benefit anyone in the ecosystem, whether it's from adult social care, children's housing, management of chronic disease, the acute trusts because of A&E attendances, bed blocking, you name it. Any actor, organization within the system can potentially benefit from a role from this at scale, certainly. So there isn't yet a national sort of prescribed funding solution that fits a role such as this. So that's one of the really big barriers. And I think locally what you end up having to do is just identifying where you can what you can do with what you've got just to get it started. But keep in the back of your mind that that is something that will need addressing. I would say the second thing that's a real barrier is finding areas that are willing to play in the sandpit. So this takes time to implement. You don't see results immediately at scale because you may start with just, say, 4 community health workers, see how you go. What they do on a day-to-day basis are tiny little micro interventions that are barely perceptible, but that over time have a huge impact on those individuals. And then over time, you begin to see signals in the data on the things that we like to measure, like preventative service uptake or attendance at A&E. So you really have to be in it for the long haul, and therefore you need partners locally who are prepared to give it that runway, who are prepared to understand and make the changes in the system to support the community health workers in their role. It's critical that they're able to go to the GP practice and speak to the GP about a resident. That integration doesn't just happen overnight because it's a new way of working. So I think those are two really, really important things to think about. There are many, many more, but those I'd say are two really important ones.
Great, thanks. And Penny?
Hi, Matthew. Thank you. It's so interesting. And Sunderland is a neighbourhood health implementation wave 1 area too, so we're very interested in this. And yeah, drawing similarities between that and social prescribing is really helpful. Most of us have social prescribing models and the funding. I'm seeing that undermined lately. I've got 1,000,001 questions, but I'll keep it focused to one big one about scale, and I'm glad you said you'd done some calculations about how many you would need, because I was like racked in my head thinking, God, how many households are there just in Sunderland, which has a 290,000 people population, and then how does that correlate down to 100 and 150? I don't know. So I was going to ask about Westminster, and if you're universal, and have you managed to, does it cover every household in the area that covers Westminster? Do you, Sunderland's very deprived, for over 40% of our populations in deciles 1 and 2 automatically start thinking, oh, where should we start? We start in the deprivation first type, and already targeting and doing all the things you say you shouldn't do. So I'm interested in that, and your approach on every household, and have you managed the coverage?
Thanks, Penny. Really important question. So there's two ways of thinking about targeting. Targeting areas is okay. Targeting people is not okay. So that's the different types of targeting I'm referring to, just to be clear. When we target people, then we're basing it on characteristics or their perceived needs or how we view it in the data. We start risk stratifying, we start segmenting. Targeting geographies is absolutely where it needs to be, because within the geography, you're going to have a huge variety of different people on the whole, right, with different needs, and that's okay. So that's exactly what we did in Westminster. We looked at the LSOAs in the bottom 10, 20% as a starting point. We then approached the GP practices that would be interested to sort of give this a go. We partnered and there was one that's happened to serve predominantly the majority of a very, very significant council estate right next to it, where about 70% of that council estate was registered to this practice. So we had an unusual amount of homogeneity in terms of practice registration, which you may want to come back to later on. We got a little bit of pump priming funding from the local authority, from public health, who don't normally do services like this, but they had a little bit available and thought they'd give it a go. And that gave us enough runway for a year with 4 community health workers. So what we did was we mapped essentially within that geography of the council estate where there are over 3,000 households. We just mapped 4 areas, buildings essentially, with about 120 give or take households for each community health worker. And then we just said, right, community health worker A, you're in that building, community health worker B, you're going to that building or 2 buildings, and you're going to that, and so on. And then it just went door knocking. So, and unearthed a huge amount of unmet needs as a result of doing so. So you have to make some choices, unfortunately, because this role, I mean, Brazil's been doing it for 30 years. They're still making choices about where they deploy their community health workers to, even at that scale. Because until it's 100% covering the entire population, that's a journey. You don't do that overnight. It's impossible to do that overnight, but you build to that. And I think it makes sense to start in LSOAs in the bottom 10-20%. You don't have to, but I think it certainly makes sense because it's likely that those are the areas with the most unmet need. But within the deployment of the community health worker, you're not asking them to target people. Right? You maintain within their area, the micro area they're working, the universal approach. That's the really important thing. So it's a sort of a political conversation where you have to, and we get see in Westminster actually over the last 4 years, a lot of residents are sort of like, why can't I have a community health worker? And say, well, we'd love you to, but there just aren't enough resources to stretch that far. At the moment, we're in this neighbourhood, that neighbourhood, because that's where we've got the resources. But we're hoping that it will grow and scale and spread so that all the neighbourhoods can each have their community health worker. And that's a political transformation as well, which isn't easy. We're grappling with it all the time because it requires the system to actually unlock resources from some services into this one, because there isn't new money attached. In terms of answering the pounds and pence question, all things included, so on costs, HR, finance, equipment, uniforms, mobile phones, lone worker devices, training, you name it, it's about 43 or so thousand pounds per community health worker per annum. Their salary is approximately band 2 or 3. So in London, it's a sort of a 29,000 pounds, give or take. And you can honestly fix that in accordance with, what you think is right. We're not mandating that, but that's our recommendation. There's a job description, other things that you could also draw on. But what that means is you often get a lot of pushback, and you think, well, there's no way we could therefore, fund, that sort of resource across the, 120 houses per person. That seems really inefficient. We get a lot of that. But actually, we calculated it would only cost about £2 billion per annum to fund community health workers across the entire country. £2 billion per annum might sound like a lot, but it is nothing when you think about all the things that they do and the outcomes that they can achieve across the entire system. That is nothing. And then when you think about what we are then spending on vertical solutions that only deal with very, very finite issues in the household and not necessarily always that well, one has to also ask, what's the opportunity cost here? £2 billion per annum is really not a lot to actually provide a service to every single household, every single month on anything in real time. That is not a lot of money. It's, what is it, 1% of the NHS budget? Just to put into context, you'll recall that we spent 38 billion pounds rather on the test and trace system for COVID. Yeah, that was one disease for an app that didn't do anything. We could have had a national community health worker workforce in place for 20 years for that amount of money, right? So one has to think about the opportunity cost with a role like this. And I think sometimes, at least from our experience talking about this for many, many years now, some of the pushback we get around the cost of such a model comes down to, I think, ideological, if you like, or philosophical approaches and the differences that we have in them, in that, coming back to the universal versus targeted, how could that possibly be beneficial? Community residents being used with NHS emails, how could that possibly work? That becomes like a lack of trust in the possibility rather than actually an economic problem.
Thank you. Welcome,
Thank
Laura.
you.
Laura's just opposite me. We've got this recorded, so you'll be able to watch the first part. We're on to the Q&A. So, Tracy.
Hi, Matthew. Thank you very much. And I suspect I might have been on this talk before, you know, because I'm sure I know this story, and it's great to hear it again anyway. I think it's great to hear about the impact on the, you know, the population health side of things, the screening, immunisations, for example, and I think that's probably where I heard it when I used to work in cancer screening. But anyway, I'm just thinking of obviously the impact. Great to hear that you've got plans to evaluate people and the impact on people, because I think we've got some obviously huge issues across the country on mental health and MSK. And that's where obviously my work that I'm involved in at the moment with the Health and Growth Accelerator as a pilot ICB, we're looking at some of that. And I think those work coaches and the patient advisory service advisors do something similar, purely not on a hyperlocal footprint, but these are people that are sitting in GP practices, are sitting in community settings, and they're fixing lots of different issues for people around, you know, the broader determinants to health, not just sort of prevention type illnesses. So I'm just wondering if you have any information already on impacts on people. I know you, like you say, if there's plans to evaluate, but is there any suggested themes there? But, you know, particularly around mental health, because it's so massive, isn't it?
Yeah, absolutely. I mean, we have lots of evidence of their impact on people's mental health, musculoskeletal conditions, all the rest of it. If you are comfortable with qualitative evidence, it takes, like I mentioned, time to see signals in population health data, like we might record, for example, in primary care or secondary care. But that we will be doing that. It will take a bit more time. But we've got literally hundreds of case studies, vignettes of community health workers, for example, residents who were in the process of committing suicide when they got the knock on the door. Okay. Residents who just needed a new armchair, actually, in order to fix the chronic low back pain that has been causing them to, be not be able to work, that's leading to their depression, that's leading to their divorce, that's leading to their social isolation. They just needed a new armchair, or a handrail, So it's that, what's the word I'm looking for? It's that insight. It's the ready availability of real-time personalized insight that the community health workers get by crossing threshold, by going into their homes and knowing what they like, knowing when they're just a little bit off color, because they know them. They know when they're a bit off color because they built that relationship. And I don't think we can get that by sitting in a clinic. Or even in community centres. You have to do it in the home. It has to be home-based to know what's going on. So I think, I mean, as you're absolutely right, Tracy, there are lots of services that we have that I think resonates. They're doing similar work in many respects, but it's that other dimension. You might find that there's just that other dimension of the four that those services are missing, that you might just need to include to get to this role. And I think increased potential for improvements in individual and population health.
Yeah, it's almost like you want to sweep up all of those people who were in these different type of roles, throw them up in the air and let them land again to actually, that might sort of solve the problem. But I just think of all of the different roles that we've got out there, and people will know, it's different in every locality. It would, if we sort of wanted to go with this model, it's almost like you're going to have dual models running side by side for some time, aren't you? Which again is the extra cost to everything. So, but I mean, I think it's a great model either way. I think it would really take some thought, but it's not too far away, I don't think. Thank you.
No, pleasure. I think you're right. I think there are some important developments, like around the neighbourhood health plan and the 10-year plan and other things. It's a shame it doesn't come with any sort of additional resource other than a bit of local coaching. But I think things are moving in that direction. I think the government's now acknowledging that neighbourhoods are really important. And this role, therefore, is sort of brilliantly, well placed to deliver at the sharp end that neighborhood health. So you're right. I think if it was as easy as sort of throwing everything up in the air, that would be wonderful. But I know it isn't. And I know systems will have to transform themselves and there'll be disruption and so on in order to achieve this, because there isn't just going to be a whole new £2 billion layer of human resource included. Things will have to be taken from elsewhere. It's also important to say that community health workers, though, work really closely with social prescribers, work really closely with many of the other roles. It's not to say that they need to all be transformed into community health workers, even though they do a lot of social prescribing themselves. There are obviously moments when a community health worker will want to refer to a social prescriber who can provide that, much more in-depth behavior change, perhaps, critical intervention for a period of time that the community health worker may not be equipped to do. But there's still many services that need to work with the community health workers. But what the community health worker does is it sort of, I think, potentiates, if nothing else, all of those services that we already have.
Thank you.
Thanks, and thanks, Tracy. Heather.
Thank you, Karen. Hi, Matthew. That's fabulous. I loved. Apologies, a meeting overran, so I missed the start of it. So apologies if my question has already been covered, but this is music to my ears, as I'm sure it is to everybody's on this call. I sit, as you can see, within the Child Health and Wellbeing Network in the ICB. So we're really comfortable with sitting in that community space, especially with children. Children spend most of their time in schools. So we're used to having to work in schools if you want to engage the children, and then working with the families and so on and so forth. And I'm just really curious to know if there was any specific impacts or even those unintended positive consequences of delivery, both in Brazil and in your sort of green shoots in the UK, for children in particular. And some I can guess myself, in that we always say take a family approach, because if mum's unwell and someone can support mom, then that will benefit the child and the healthy eating and all those things. And we have our own core 20 in the northeast and North Cumbria that's focused around some of those wider determinants, and it has like healthy environment and stuff like that. So I'm assuming there's lots, but just curious, and apologies if you've covered it.
No, not at all. Thank you for the question. I'm sort of struggling to think of unintended consequences that aren't actually beneficial to the work that we've been doing here in the UK, because at the moment what we're picking up on is just incredible, benefits from the community health worker world, where people have sort of unearthed problems that no one knew about, or solved problems that hadn't been solved for many years, and so on and so forth. So I think one of the things that people were expecting was a tsunami of need that we wouldn't be capable of addressing, and it's been the opposite, actually. What we found is a reduction in service utilization and primary care, because, of course, it's all being done more in the home. So the sorts of conversations that GPs often spend 40% of their time dealing with, filling in housing letters or other stuff, admin or something like that for residents, noise, we might call it, not actual clinical care, is being dealt with by community health workers in those localities, which is, I think, really, that was I think it wasn't unexpected for me. I knew that would happen, but for our colleagues who were new to this approach, they were expecting a tsunami of demand. It wasn't the case at all. I think it's become, in Brazil, they've gone through an interesting trajectory that is also leading to some unintended consequences, which we ought to take the opportunity to learn from as we're developing our system here. And that's to say that the community health workers have become unionized in Brazil. They're, in fact, as it happens, the only healthcare cadre in Brazil to be part of a union and have their job enshrined in law. And they've done that through their sort of political movement as community health workers. With 300,000 of them, that becomes a really important force in terms of politics, because they're going door to door in their communities. The risk, and we do see it in Brazil, is that they influence voting, and that's not great. So, because that's not in their gift, right? They have to be careful not to do that. So in the same way you get good doctors, bad doctors, you sometimes get good you get good community health workers and not so good community health workers that are so beyond the reach of their role. And that's something to look out for. And actually, based on that, what we've done is make sure that when we recruit our community health workers, that they understand that it's not in their gift to influence people's politics. You know, they're there to help with health and social care needs, not to try and swing votes. And there's always a chance that politicians abuse that system. But the unionization has led to salary increments in Brazil that warranted for the community health workers, but are now not available to neither nurses or doctors, and they all work together in the same team. So you now have community health workers on the same salary as nurses, and that's not because they shouldn't be getting those salaries, but because nurses aren't unionized and haven't been able to put the pressure on the government to increase their salaries in line with inflation. And so that causes internal tensions within the team. But that's, I think, Brazil's situation. We need to separate what's happened in Brazil from what's happening here. It's just to say that there will be unintended consequences, I'm sure, but we're a bit early in our delivery model here in the UK to know what those are.
Thank you, and apologies. I think it was my poor English. I meant positive unintended consequences, i.e. what are the benefits for children? And I could see, you know, when I joined, you'd highlighted some of the immunisation rates, but I was just wondering, what are the benefits for children? Because I imagine, and often with health, a lot of the benefits or the focus is on the adults because it's the larger population and it's those usually in poorer health. So I was just curious from a children's perspective.
Thank you. Sorry. Well, then let me answer it quickly, because of course the positive benefits, I mean, they're manifold. You know, firstly, healthy, happy adults and parents make for happy, healthier children. The community health workers make sure that their mothers, when they're pregnant, they're the first people who know that they're pregnant usually, and they make sure that they attend their antenatal consultations and get the breastfeeding support. And be seeing, certainly in Brazil, 6-month plus rates of exclusive breastfeeding, almost 100%. In the community where I worked, there was 100% childhood immunization coverage. The community health workers know exactly which child is due their immunization and when, and can make sure that they get it. If they miss their appointment, they help them get one. And another one, you know, pertussis immunization in pregnancy. I'm trying to think, truancy, identifying truancy, gang-related violence, radicalization, dare I say, is an important issue these days. If you've got a community health worker spotting when people are getting radicalized, we could potentially find that to be quite helpful in this country, as well as in any country. In my community, we actually had the community health workers set up an adolescent group that all the teenagers that were at risk of gang violence all got together every week to talk about sexual health, HIV, condom use, drugs, all the rest of it. So it was educationally important. But then they ended up deciding to put on a play that they wrote and acted themselves for the community about condom use and its importance to prevent HIV. And some of them went on to become professional actors. You know, so I showed you the pictures of the community that I was working in. Can you picture the extraordinary transformation that's required for a teenager in that environment to then go on to become a professional actor as a result of that community health workers work? You know, it's really transformational, I think. So, you know, I think the results of the community health workers touch on them not just from a, you know, the health and social healthcare point of view, but social care and, you know, all the way into adulthood.
Fabulous, thank you. Sounds amazing.
Thanks, Matthew. If it's all right with you, Penny, I'm going to ask a quick question and then hand over to you, and then we'll wrap this element up so that we can excuse Matthew. My question is twofold, two questions in one, but the first bit I think is quite quick. I'm thinking about positioning, and I'm thinking about things like the digital passport and all the stuff that's been in the press recently, and this concept of knocking on somebody's door, and how they're received. And I suppose there is a bit of a safety element to that, but it was more about just that, you know, people don't like, you know, post put through their door, do they? And they stick something on the front door that says, no flyers, please. How that's managed, or is it just, it is what it is, and if people don't answer the door, that's it. But the bigger question, I suppose, is one of, I can imagine every community health worker will do it differently to a degree. That's okay, isn't it? And how do you train people for this? Because again, it feels like, you know, on day one, these people will go in and they think, what I only know what I know through my own lens and through how I've lived my life. So, you know, is there standardization of that, or is that okay, that how people support?
Thank you. Yeah, absolutely. This is another really big one. It's a changing culture, not just for us as system leaders and service providers, but also for residents going door knocking. It's not entirely acceptable to a lot of people. It's novel. It's a changing culture and attitudes, right? So what we measured in Westminster was the number of door knocks or approaches that were required to convert into a home visit. And it began with 11 door knocks to convert into one home visit. That's just to give you a sense of just how hard it is. You need to recruit people who have the perseverance, the the wherewithal, the integrity, but also the ability to gain trust from residents so that they do actually eventually open the door. But when they open the door, there's no attrition whatsoever. That relationship is established. They visit them the next month, and so on and so forth. We've not seen anybody not want a community health worker once they've met them. The second thing to say is that that's improving over time. So you've got to have a sense of the sort of duration that's required to implement something like this. It took about a year for that to go down. So about what we have now is 4 door knocks to convert into a new home visit. And of course, now that's because they're more visible. People in the community now know who they are, but people are still sometimes not at home, right? So it can take a lot of repeat visits before you actually get into the home. But we find that the home visits become a lot shorter. They know each other. There's a shorthand. You only need to necessarily spend 10 minutes just for a catch-up cup of tea, and then you move on to the next home. You start with leafleting, and that's why it's important to work with the primary care practice, because they will give the list of registered patients and where they live and their addresses, so that you can write a personalized letter and say, we're developing a new service. It's part of the GP practice. It's commissioned by the local authority, whoever it might be. But this is a trusted individual from your neighborhood. They're going to be knocking on your door. Here's their number. Here's their picture. So don't be surprised, and we hope you like them, so to speak. And that's where it begins. And sure, a lot of people turn around at the beginning and say, no, thanks, I'm fine, I don't have any problems. And there are plenty of cases where community health workers have taken 2 years listening to people say, no, it's fine, I'm fine, don't have any problems. Then they finally do go in and they have so many problems that they weren't even aware of a lot of the time. So you really do need to persist. That's why I said at the beginning, don't bother doing it for 1 year. You won't achieve much in 1 year. You need to do this for at least 3. In terms of safety, of course, community health workers have to behave in a professional manner. And so part of the training, which only takes about a month, is to understand, well, what's the NHS? How do you behave professionally? We train them in just listening, which is a dialogical approach to understanding people's needs, not just arriving with an agenda, but waiting to hear what they want to say. Training in a number of different clinical conditions, immunization programs, and so on and so forth. But importantly, they are supervised on a weekly basis with the clinical lead or champion in the practice. So in Westminster, it's my colleague, Dr. Connie Jungens, who's the clinical lead for the Westminster Community Health Workers, and she meets with them on a weekly basis to talk about complex problems in the households. Use that as a learning opportunity to take forward, thinking about, well, there was an issue with mold, and so, well, okay, let's talk about mold and, what causes it and how do we solve it. Each week it's a new theme, if you like. So very, very quickly, what we see are people who are recruited who wouldn't say boo to a goose and, don't know very much at all about in terms of healthcare, becoming incredibly expert over a period of just a few months in a variety of different health and social care conditions, and confident in doing so as well. So just this afternoon, I mentioned we got the Minister of Health from Brazil coming to visit our work in Westminster. I've got 6 community health workers who are going to stand up in front of the Minister of Health and present their work to them. These are just regular people, right? So, it benefits them as well as, I think, the household.
Thank you. And did that cover your question, Penny? Did I read your mind? You did.
Yeah, you did. Sorry, I couldn't find my mic there. Yes, you did. Thank you, Karen.
Brilliant. So we don't want you to be late for the minister. But I want everyone else to stay just for another 10 minutes if you can, because I want to do the so what bit. But Matthew, I'm sure I speak for everybody in saying that this has been an absolutely brilliant session, and we're so grateful to you for the work that you're doing and have been doing, and obviously bringing that to us. And my promise to you is that we'll share this, and we're going to share this out to the system. So and hopefully we can keep in touch. So you'll need to get your skates on because you've got to go across London, haven't you? So thanks again.
Thank you. Can I just say thank you very much for the opportunity? You know, I do lots of these presentations. We don't always get such receptive audiences, but I found this today to be absolutely wonderful. So thank you for your interest. I would also say that if you want any further information, if you feel collectively that this is an avenue that you think is worthy of exploration, then just get back in touch, because I didn't mention that we have a community of practice nationally led through the National Association of Primary Care, which I'm also leading with others. And we meet every quarter, program leads involved in this work, to share learning, troubleshoot, ask for advice, all that sort of thing. And we have resources available for localities wanting to come on board with this sort of role around sort of, for example, standard operating manuals, job descriptions, logos for their uniforms, all that sorts of stuff. So I can put you in touch with my colleague Marcus McAllister, who's our program manager at the NAPC, who deals with all of that and would be able to share all of those resources with you once you're ready to consider them.
Brilliant. Fantastic. Thanks again.
Thank you. Take care.